So I've been doing this OLLI procedures for a while, and prior to that, I've been doing the LE procedure for several years too. And I really like these procedures because you can put a very large implant in the strongest part of the vertebral body, and you get this ligamental textus, and you get a fantastic spinal canal decompression. And the implants that you place in the vertebral body is quite large, so you can pick a lot of bone graft in it. So non-union is quite rare. And because of this kind of procedures done with a patient lateral decubitus position, and you can access to front part of the body and the back part of the body, so single position spine surgery is possible. So I've been kind of pushing the envelope a little bit, and I've been trying to correct ASD, adult spinal deformity, with these procedures. And the idea is pretty simple. It makes sense too. So you put this implant in the strongest part of the vertebral body, and it's going to give you a very aggressive correction because they usually don't subside because you're putting a buffer bone of the vertebral body. And then it's going to give you a very strong anterior column support. So theoretically, you should be able to make a correction of the deformity with a less fusion level. And you can also correct sagittal plane imbalance by putting a lordotic cage, hyperlordotic cage, or expandable cages even. So this is one of patient that I performed the surgery, and she's got a severe spinal stenosis of the L2 to S1. And she also, as you can see, has got sagittal plane imbalance. So I performed all lip of the L2 to S1 and percutaneous pedicle screw fixation of the L2 to S1. And you can see that the sagittal balance has been nicely corrected. So I was quite encouraged and I kept doing it. But I realized that there is a significant limitation in doing what I want to do. You cannot get a segmental differential correction of the coronal deformity with this parallel cage that I've been placing in. And because when you put a parallel cage from lateral position, whether it's all-lip or ATP or L-lip, you are evenly increasing vertebral body height, disc height, evenly on the left side and the right side. So this is a good thing if the patient has a coronal plane imbalance to begin with, because of the due to asymmetric disc degeneration, then you can take care of the spinal stenosis at the same time when you take care of this coronal plane imbalance. You get in trouble when the patient already has coronal plane balance. And one could have a scoliosis, but it could be balanced. In that case, if you put a parallel cage, by elevating disc space even on the right side and left side, you can actually throw the curve up to one direction and make the coronal balance much worse. So is the coronal balance important? Well, nowadays, all the focus of attention of the ASC has been a sagittal plane imbalance. And Dr. Frank Schwab played no small role in this phenomena. And he wrote several articles, and one of them, he stated that the frequently used coronal angle, Cobb angle measure lacks correlation to health-related quality of living measures in the above reference studies. And he also went ahead and said, malalignment in the sagittal plane results in disability most consistently expressed in ASD patients. But we got to understand that the coronal imbalance is not the same as Cobb angle. One could have a large thoracic and a lumbar Cobb angle. It could have a perfectly balanced spine. And there are plenty of eminent surgeons who still think that the coronal balance is important. Well, what about the iatrogenic coronal balance? This is what I want to talk about. What about the patient had balanced spine in coronal plane, and a surgeon, in an attempt to correct this problem, and you put this parallel cage and create a coronal balance imbalance, a coronal plane imbalance? This kind of problems are very poorly tolerated. So I'm going to show you some of my anecdotal experience, and I don't have any conclusion for that, but I just want to show you some of the x-rays of the patient that I operated. This is a 62-year-old lady and with degenerative scoliosis with a severe spinal stenosis and neurogenic claudication. That's an MRI. As you can see that she's got central canal stenosis, 2, 3, 3, 4, quite severe neurofractal stenosis, and 4, 5, 5, S1. So, what I did was all lip of the L2 to S1 with supplemental percutaneous pedicle screw fixation of the L2 to S1. So it looks pretty good, and the patient's happy. And her neurogenic claudication went away, her back pain went away. So she was quite happy. So when you compare the X-rays pre-op and a post-op, in a pre-op, you can see the patient's spine is not balanced in the coronal plane due to asymmetric disc degeneration. So in this case, by placing this parallel cage in the lateral position, or lip or L, whatever, you can actually correct the coronal plane imbalance and iron out the spine very nicely. And by placing this lordotic cage, you can correct the sagittal plane imbalance at the same time. So this is good story. And another patient is a 57-year-old man with a degenerative scoliosis, neurogenic claudication, radiculopathy, and an axial back pain. And I took care of this gentleman, and most of his pathology is concentrated between L2 to S1. So I performed all lip of L2 to S1, and I supplemented with a percutaneous pedicle screw fixation from L2 to S1. And he did great. His back pain went away. He's walking good, and he was very thankful and with a good outcome of the surgery. So look at the X-ray pre-op and post-op. And pre-op, this guy already had balanced coronal spine. And a post-op, I put parallel cages without actually disturbing a coronal plane. So I did not disturb his coronal plane. And this is sagittal plane, and he had a mild sagittal plane imbalance due to a disc degeneration. And by putting a lordotic cage, I was able to improve the sagittal imbalance. So he did great. So I got stoked, and I emboldened, and I started doing the same thing to pretty much everybody. And when this is a 68-year-old lady, she's actually a colleague of mine. She's been sending a lot of spine patients to me. And she came in and, hey, Sean, I got this problem. And, all my patients are doing great. And you think you can take care of me? And she said, I got some other opinions in the city. And everybody said I got to have a T9 to S1 fusion. And there's some guy who even said I need a T5 to S1 fusion. So what do you think? So I say, and I've been taking care of this problem with this great procedure known as OLIP, and I don't think you need that T9 to S1 fusion. And I was thinking that I should be able to elevate this, scoliosis, elevate the disc space and correct it. So how about an L1 to S1 fusion sound to you? And she said, that's great. Let's do it. It's much better than T9 to S1. So that's what I did. I did an L1 to S1 OLIP and a supplemental percutaneous pedicle screw fixation. So I knew this was a little different scoliosis. So what I did was intraoperatively, I did MIS osteotomy. So through the small incision, I obliterated the facet joints with a high-speed burr, and I tried to distract the left side. And then this is X-ray that I got. And postoperatively, the patient did not do too well. And she said, my leg pain's gone and I'm walking better, but I got this horrible back pain. It's just not going away. It's gonna get better. So I said, it's probably gonna get better. It got worse. And, she's saying, why is it not going away? Well, I looked at the X-ray. Well, preoperatively, her spine looks horrible, but at least she had a balanced spine in coronal plane. Postoperatively, what I did was I put this parallel cage into the degenerative segments and elevated the spine, and I elongate the curvature and threw the curvature to the left side. So probably the only way to correct this problem was actually doing a T9 to S1 fusion, but I didn't want to do it, so I did L1 to S1 fusion. But in reality, she's got a coronally imbalanced spine with a C7 PL of the 6 centimeters. So, and this is a sagittal plane too. And, preoperatively, her sagittal plane, although spine was ugly, at least it was balanced. But postoperatively, I made her sagittal plane even worse too. Scoliosis is a 3D deformity. So if you mess up coronal plane, chances are you're gonna mess up sagittal plane too. So she's still mad at me, and she stopped sending the patients to me.
Oh.
What about this gentleman? He's a 78-year-old guy, and he's got a severe spinal stenosis, and he can walk, and he can walk 100 feet. And then I looked at him. Well, you got scoliosis, but that's not what I'm fixing here. And you're old, you're not a very healthy person. Of course, I didn't say you're old, but So, and what I'm gonna do is I'm gonna fix your spinal stenosis. That should be the main goal of your surgery, not necessarily trying to make your spine better looking. So he says, sign me up. So this is what I did. I did all lip of the L2 to S1 with a supplemental percutaneous pedicle screw fixation. And guess what? He says, well, my leg pain is better and I can walk better, but my back pain is just horrible. It's just not getting better. So look at that. And this is pre-op x-rays. His spine was ugly, but at least it was balanced. Post-op x-ray, I threw the curvature to the left side. And I did this procedure to correct his spinal stenosis. Yes, I did correct his spinal stenosis with a ligamental taxis, but I made his spinal curvature much worse in a coronal plane. In a sagittal plane, again, it got worse too. It is three-dimensional deformity. Now, I saw this lady, a 64-year-old lady who had an L4-5 T with instrumentation. She did surgery 4 years ago. She had this surgery done some, well-known national institution in Philadelphia, and you all know where that is. And she came in and, ever since surgery, I'm not doing well. I got this back pain and then I got this leg pain. And I looked at this x-ray, they go, so, Rothman Institute is not such a big deal. Look at this horrible x-rays, right? And then this is not a very beautiful job. So I said, I can do better. So this is what I did. And this time, actually, I tried to correct the deformity in addition to spinal stenosis. So I did an ORLIF of L2 to S1, and I did a supplemental percutaneous pedicle screw fixation from T10 to S1. So she's saying that, my leg pain is better and my back pain is better, but, I don't know why I feel like I'm shifted to the left side. So I said, stand up to the right. No, I just cannot stand up straight. And, look at the x-ray and before surgery, no matter what an ugly job the previous surgeon did, at least he did not violate the balance, which was existing. But me, in an attempt to make the spine better, I actually shift the spine to the left side and gave her a C7PL, the 5 centimeters. Is that a big deal? Patient thinks so, and she's not standing up straight. So I learned lessons. For degenerative scoliosis, correcting sagittal balance alone can disrupt the coronal balance. When there's a balanced scoliosis, and the parallel cages that I've been using will accentuate the scoliosis that throws up the curvature unless fusion is done from stable zone to the stable zone. And this iatrogenic scoliosis, coronal imbalance is very poorly tolerated. And you have to respect this existing balance. And also I learned that I put a parallel cage and I tried to distract posteriorly with the MIS procedure. It doesn't work. And you try to do the osteotomy through a small incision and try to distract it. Because you don't have any anterior column, it collapses right back. Or you may get a hardware failure too. So here's my dilemma. This only procedure that I learned to love, and I've been creating a really good outcome, and people do so well with a minimally invasive spine now, with a minimal blood loss and minimal morbidities. So I want to continuously offer that to my patients. But in the process, I've been creating all this coronal plane imbalance. Then am I going to fuse the entire spine to correct the deformity as well? I'm not sure a lot of my patients who need this kind of surgery can tolerate that kind of procedures. And it also defeats the purpose and the spirit of the minimally invasive spine surgery. So how can I fix this degenerative condition with MIS without disrupting existing balance of the spinal column? Is that a way to achieve and not to disrupt the global balance of the ASC without long fusion and with MIS indirect decompression utilizing ORLIF, LLIF, ATF? Can it be done with a minimum? Can it be done with a minimal spine segment fusion so we can do SPS? The correction of the sagittal plane can be achieved with the current technology. We have hyperlordotic cage, we have expandable cages, and you can also release ALL, and it's not such a difficult technique, you can do all that. But the correction of the coronal imbalance has been the challenge. There are some steps forward. There are some expandable cages with a fixed lordotic and fixed coronal angle. It is not really expandable cage. It's already fixed about 4 degrees. So you're kind of basically expanding it, and you're not really correcting the coronal balance. I got more stories, but let me just show you. And it can be pretty powerful. And a 4 degrees lordotic, coronal cage, you don't think it's a big deal, but so like something like that, you can convert into something like this. It's not perfect, but you can make significant difference. Imagine what you can do with a truly expandable coronal plane correcting spinal cage. Thank you.
Thanks. Thanks, John.